Conversation analysis. Assessing meaningful communication in people with aphasia by Brydie and Brydie Tesh.
Conversation analysis is the process of analyzing and coding a videotaped conversation to examine conversation features such as conversation repair strategies and speaking efficiency features like speaking rate and length of utterance.
Why use conversation analysis to assess people with aphasia? Even though conversation analysis has quantitative aspects, the analysis provides a clearer description of a client's ability to converse than other standardized measures, such as picture naming tasks. Most formal assessments do not incorporate a natural conversational element with a familiar conversation partner. Observing the client in this setting shows their strengths and weaknesses in true conversation or communication. The clinician can see directly what the client needs in therapy.
How can clinicians use conversation analysis to assess people with aphasia? Clinicians can analyze and code a videotaped conversation. Code means to label and categorize aspects of the conversation. The most common conversation features that are coded are below. Conversation repair strategies are broken up into two categories: other repair and self-repair. Other repair involve a model, reflection, cue, request for clarification, and undifferentiated request for clarification, such as the person just saying what or huh. Self-repair is, of course, when the person repairs their own mistake in conversation. Speaking efficiency features can be calculated with software programs. These software programs can also help you analyze and synthesize your data in qualitative and quantitative aspects.
Study 1. Conversational Discourse Analysis as a Method for Evaluating Progress in Aphasia, a case report by Larry Bowles, 1998. Purpose. The study was completed to document the change in conversational features that parallel improvements shown on standardized and other formal testing on an individual with aphasia through a 7-week course of therapy. Method. A 47-year-old woman, we'll call LNC, who suffered a left basal ganglia infarct 7 months prior to the study, was observed. She received 12 weeks of speech therapy post-onset. Her sister-in-law, who lived with her, served as her communication partner. The study design is classified as a single subject, within subjects, withdrawal design with an ABA pattern. This study also has a concurrent nested design, since more importance is attributed to the qualitative data than the quantitative data in this study. Conversations were held for initial assessment. LNC received 7 weeks of therapy, 2 one-hour sessions weekly. Prior to the first session of the week, LNC and her communication partner were videotaped having conversations in the home for 20 to 40 minutes. One follow-up conversation was held for reassessment after the 7 weeks of therapy. The researcher used a 10-minute sample of each conversation to analyze. An analyzing software was used, and the researcher developed a conversation repair tier to calculate the frequency of coded conversational repairs, including self-corrections, requests for information, or clarifying a statement.
The researchers found a decrease in the severity of aphasia accompanied by positive changes in LNC's self-reported psychosocial well-being, functional communication, and communication readiness and use. LNC doubled her words contributed to the conversation and tripled her rate of self-repair. Her partner showed a modest decrease in speaking rate, and she used fewer words per utterance. Her total contribution of words to the conversation declined from 91% to 82%. Her rate of conversation repair did not change significantly over time. Success in therapy has traditionally been judged by standardized test scores. This study indicates that other methods exist that will yield valuable information about the communication skills of clients with aphasia. Clients, family members, and care partners get the benefit of growth that is shown in therapy from assessments of conversation, which are true indicators of successful communication. Strengths of this study include that it examines conversation repair as a dependent variable over a span of several weeks in a woman with aphasia, rather than only examining conversation repair with a descriptive study design. All questionnaires and tests were given by a competent professional who is not familiar with the objectives of this study. 3 baseline conversations were recorded and analyzed, so this multiple baseline study design is a strength. The conversations that were videotaped during the 7 weeks of therapy were recorded before the first therapy session of each week to prevent the immediacy effect, in which strategies learned from therapy would be used immediately after the session, but not later on.
One limitation of the study is the difficulty in replicating the study. Bowles wrote that it takes between 6 to 10 minutes for every 1 minute of video in order to analyze properly. Also, adding 20 to 40 minutes of conversation time before a therapy session might pose a problem for some subjects. Being a case study is also a limitation because it is not a representative sample of the entire aphasic population.
We chose this article because it shows how conversation analysis works and gives insights into the procedures that we will use in our study. Our study will be a case study as well, so information on the proper way to implement this is helpful. This article also answers why conversation analysis should be used with people with aphasia and how it should be done. Our second study is by Perkins, Crisp, and Walshaw. Exploring conversation analysis as an assessment tool for aphasia, the issue of reliability. The purpose is to address the idea that assessment methods that use natural interaction lack reliability because of variability in conversation through comparison of quantitative and qualitative analysis of collaborative repair. 8 participants who were at least 6 months post-onset of a CVA were studied. None of the 8 were in speech-language therapy during the study. Each client chose a conversation partner with whom they interacted regularly. 5 of the conversation pairs were video recorded for 20 minutes in their homes once a week for 4 consecutive weeks. The other 3 pairs were audio taped on the same schedule. The first 10 minutes of each recording was transcribed and analyzed using a language analysis software. Researchers determined the number of major turns involved in collaborative repair and divided it by the number of major turns in the conversation for a quantitative measure. The qualitative analysis consisted of identifying the moments of trouble in the conversation that led to conversational repair. The researchers also identified the interactional mechanisms used by the pairs to address the troubling moments. The study found there was a great between-participant variation in the proportion of major turns in collaborative repair. Each participant's results were listed separately in the study. The researchers found that most of the clients were consistent in the nature of their trouble sources. They also found that 1 or more trouble sources were observed in all 4 conversations for each participant. The significant within-participant variation in the quantity of collaborative repairs brings into question the use of quantification of conversational behavior as a reliable measure of change over time. The qualitative analysis reliably indicated the interactional challenges experienced by people with aphasia and their conversation partners. We chose this article because it took a skeptical, honest look at whether or not conversation analysis is a good assessment for a clinician's busy time schedule. In the end, this article did conclude that it is both practical to assess the client's conversation needs and practical in a clinician's busy time schedule. Our third study is by Booth and Perkins, the use of conversation analysis to guide individualized advice to carers and evaluate the change in aphasia. Booth and Perkins explained how they used conversation analysis in pre- and post-therapy assessment of a man with aphasia named JB and his conversation partner RB. As a pre-therapy assessment, conversation analysis caters therapy to address the specific needs of a person with aphasia and his conversation partner. Comparing the pre- and post-therapy conversation analysis assessments shows the effectiveness of a particular therapy program. The researchers used CAPA, which includes 3 parts: an interview with the main conversation partner to the person with aphasia, conversation analysis of a 10-minute conversation between the person with aphasia and the conversation partner, and a comparison of the interview and conversation analysis. Through conversation analysis of the pre-therapy conversation, the researchers found long, unnecessary repair sequences. Group therapy focused on teaching RB to encourage JB's involvement in the conversation by following the least collaborative effort model for conversation repairs. This study uses a single subject within subjects withdrawal design with an ABA approach. The study also has a concurrent nested design since the data is analyzed both qualitatively and quantitatively, but more emphasis is given to the qualitative data. Conversation analysis of the post-therapy conversation showed 29% of the conversation turns were conversation repairs. This is a huge improvement from conversation analysis of the pre-therapy conversation, which 87% of the turns were conversation repairs. During the post-therapy conversation, RB did not try to get JB to correct errors that did not interfere with RB's comprehension of JB's message. Instead, RB only addressed JB's errors that interfered with his comprehensibility and enabled JB to be as involved as possible in the repair sequences. JB initiated topics more often in the post-therapy conversation, which is probably because he felt more confident knowing that if confusion did arise, he had a supportive conversation partner who was equipped to help resolve the confusion as quickly as possible. Because repair sequences were quicker, the topics that JB initiated were further developed rather than being derailed by these long, unnecessary repair sequences. JB also took more initiative in the post-therapy conversation by requesting clarification when he didn't understand a certain aspect of RB's utterance. Conversation analysis is effective as a pre- and post-therapy assessment because it guides therapy to address specific needs of a person with aphasia and their familiar conversation partners. It shows the effectiveness of group therapy for people with aphasia and their conversation partners, and highlights gains made during therapy that standardized tests do not reveal. The participant has a fluent aphasia rather than a non-fluent aphasia. This is a strength because most participants in similar conversation analysis research studies have non-fluent aphasia, so this provides a unique perspective. This study interviews the non-aphasic conversation partner before and after therapy. The information gathered from post-therapy interviews strengthens the validity and reliability of the conversation analysis information because the information from both of the conversation analysis and the post-therapy interview match each other. Limitations are that this study only analyzed one conversation between JB and RB for pre-therapy evaluation and only one conversation between JB and RB for post-therapy evaluation. A multiple baseline study design, like we looked at with the Bowles study earlier, would have been an excellent way to strengthen the external validity of this study. This study did not explore JB's perceptions of what aphasia is, the psychosocial impact of his aphasia, and the usefulness of the conversation strategies that he and RB use. This study showed the usefulness of interviews to strengthen the findings of conversation analysis. In our study, we will interview the familiar conversation partners and unfamiliar conversation partners to assess their understanding of topics like the impact of aphasia and conversation strategies. So, bringing things full circle, why use conversation analysis to assess people with aphasia before therapy? Why use conversation analysis to reassess people with aphasia after therapy? And how can clinicians use conversation analysis to assess people with aphasia? Many studies have discussed why and how conversation analysis is used to assess people with aphasia, yet nearly all of these studies have examined how people with aphasia communicate with their most familiar conversation partner. While it's essential that a person with aphasia communicate well with the people they spend the most time with in their life, it's also important for a person with aphasia to communicate well with less familiar conversation partners, such as people they're meeting for the first time. There is much usefulness in a person with aphasia learning strategies to communicate with unfamiliar conversation partners who may not know how to support them. This is especially true for people with mild to moderate aphasia who are less likely to have as many concomitant health problems, so they're able to go back to work, be involved in social settings where they meet new people, and be independent from their family in other ways. The purpose of this study is to use conversation analysis to assess the ability of a person with aphasia to communicate with his most familiar conversation partners and unfamiliar conversation partners. Conversation analysis will be used to evaluate repair strategies and speaking efficiency of the person with aphasia in the conversations with his familiar conversation partners compared to his conversations with unfamiliar conversation partners.